Bonjour à toutes et à tous.
Good morning, ladies and gentlemen.
Comme les diapositives sont en anglais, je vais
As
parler
these
en français.
speeches are in English,
Le meilleur
the slides are in English, I'm going to be speaking in French, and I'm relying on the interpreters. So thank you very much to Rock for the invitation.
Une petite diapositive de déclaration de conflit
Here we
d'intérêt
have
sur
a
la chose la plus
quick
importante que
slide
vous
about a
ayez
conflict of
puisque je ne suis
interest.
pas un
I
universitaire en
am
sciences
not
politiques,
an
ni
academic
management
in
ou relations
in
publiques.
political sciences.
Ma discipline
I
de base, c'est la médecine physique et
I'm
réadaptation.
really a
Et donc,
physical
ce que je vais vous
medical
dire est avant
expert,
tout
all
issu
specialized in
des Nations Unies.
readaptation.
Et puis,
So
merci de
thank you
voir un
very
petit
much
peu
for
dans le
having me
ciel, ce qui
today.
vous
I
donne un concept
have
comme ça,
a lot of
à la fois
experience
comme
in
chef de
the
service d'un
relevant
service de
topics. So
médecine
I've
physique
always
et
worked as
réadaptation
a head of service,
et
head of
dans le
department
champ
in
de la formation des professionnels de santé
hospitals, and
et
I
des
have worked
professionnels
on
de la santé.
training healthcare professionals for many, many years.
Alors, la première chose qu'on peut dire du sujet qui nous
So the
occupe
first thing that we
ce
can say
matin, c'est
about
que c'est un
this
sujet
morning's
auquel
topic
sont
is that
confrontés les
we are
gouvernements et les
dealing
populations
with
partout dans
many
le monde.
different
Et
issues, and all of this
partout
is
dans le monde,
affecting
on rencontre les deux mêmes
populations around
problèmes.
the world. And all of
D'une
these
part,
populations are
l'insuffisance numérique
dealing
du
with, first
nombre de
of all,
professionnels
the
de
lack
santé,
of
et
healthcare
d'autre part, une
professionals
tendance forte de ces professionnels de
and the
santé
fact that
à se
these healthcare
concentrer
professionals tend to
dans les grandes
concentrate
métropoles
in
et à
urban
être
areas
insuffisamment présents
and
pour
underprivileged
livrer des
poor
services de
areas,
santé aux
unfortunately.
populations
So
pauvres
they
et
don't really
vulnérables.
exist
C'est un
to
sujet
help the most
qui est
vulnerable
à
populations. So this
l'agenda
is a
depuis plus
topic
d'une vingtaine d'années,
which
et
has
vous
been a really
avez
hot
sur cette
area for many
diapositive
different years, as you can
un
see on
document qui est tout
this
à fait intéressant à
slide.
lire, qui date maintenant
The
de 2016
publication on the
et
slide
qui est la
was actually
déclaration de
brought
l'Organisation
out in
mondiale de la santé
2016, and it
sur la
was
question des
made
ressources
by
humaines en santé,
Ban Ki-moon,
avec deux
who was
chiffres qui
the
doivent
United Nations
disparaître ici.
Secretary General. So
L'idée qui
several different
manquerait en
key
2030, c'est-à-dire
figures. So,
demain
for
matin,
example, by
environ 18 millions
2030,
de
we're
professionnels de
going
santé
to
dans le
be having
monde,
a lack of
qu'il
about
était
18 million
nécessaire
healthcare
de
professionals in
former
the world.
environ
Therefore, we
40
must
millions de
absolutely
plus que ce qui
train
était
about
prévu.
40
Donc, ce n'est pas un
million
problème à la marge.
of these healthcare professionals than we're currently planning to. So
Alors,
that is a
pourquoi est-ce
great
que j'ai
issue.
choisi ce sujet? Plutôt parce
Why did I
que
choose
il y a
this
l'air de trouver que
subject?
c'était
Well, that's
éventuellement une
because
bonne idée.
Rock really found it to
Pour
be a good
quatre raisons, et
idea
je
for
vais
four main
citer que
reasons.
deux
And I'm
sur
just
cette
going to look at
comparaison-là,
two
sur la
of them,
diapositive.
which are in bold on the slide.
Premièrement, parce
First and
que
foremost,
l'état de santé d'une
because
population,
the
je
health
ne vais pas faire l'injure à un
status of
public de santé
a
publique de vous apprendre qu'il ne dépend
population.
pas principalement du système
Well,
de
I'm not going
santé.
to tell you everything about how the health
Environ
status of the
15%
population
sans doute. Pour autant, il
depends
dépend quand
on
même un
healthcare
peu du
professionals
système de
entirely,
santé.
but they
Et
do
par contre,
indeed
le
depend
système de
partially on
santé
the
dépend,
healthcare
lui,
system.
beaucoup des professionnels de
And it
santé dont il
really
dispose.
does everything
Deuxièmement,
basically
parce
pivots
que
around the
ça a une
availability of
influence
these
en
healthcare
effet
professionals.
sur l'état
So
de santé
it
de la
also
population. Les difficultés
depends
d'accès à la
on the
santé sont
access
très mal
to
perçues par les populations
healthcare
et
and the
donc,
way
en
that
effet, par
populations
les
perceive
gouvernements
this
qui
access. So
souhaiteraient
that's
être
really
dans cette
up to
condition, et
people who work
que
in
ces
government.
difficultés
And
sont
these
vraiment un des
issues
éléments
are
qui
very clearly one of
renforcent
the
les mouvements
key
populistes
factors which
en Europe
strengthens
et
a
ailleurs.
populist movement in Europe and
Troisièmement, je
elsewhere.
vais traiter ça que de
Thirdly,
façon
I am
très à la
going
marge,
to
parce
be
que si on n'a pas une
dealing with
planification
things step
correcte
by
des
step because we
professionnels de
don't
santé,
plan out
potentiellement, on
how
met en
healthcare professionals are
danger
going to be working
toutes
in the
les autres
future, then we're going to be
planifications. On n'est capable, et
jeopardizing
ça a
all
été fait
kinds
dans le
of
monde, de
planning
construire des
in Europe
hôpitaux
and
qu'on ne
around
pourra
the
pas
world. How
utiliser
can
parce qu'on
we
n'a pas
build
d'équipement
hospitals which are
maintenant,
not necessarily
ou d'acheter
going
des
to be put
équipements
to use because we
radiologiques
might be
sophistiqués qu'on ne pourra pas
lacking
utiliser parce qu'on n'a pas de
nurses or
radiologues. Donc c'est vraiment un
lacking
véritable effondrement
radiological
des
equipment
capacités
because we don't
du
have enough
système de santé.
radiologists? So
Et puis
all of
enfin,
that
et c'est
is really
essentiellement de
relevant.
ça
And then
que je
finally,
voudrais vous convaincre,
I'd also like to
pour
convince you
qu'éventuellement vous
about
sortiez un
something
peu plus
so that
bienveillant vis-à-vis des
you
politiques qui
can
se
come
sont
out of this a
trompées, que
little
vous
bit
venez de
more,
rentrer,
a
essayer de
little
vous
bit a
montrer
kinder
que c'est un
mindset about the
problème qui a l'air simple, mais
politicians
apparemment
working
qui est
in the healthcare
exagérément compliqué.
area. They're dealing with many different issues
Alors,
and
deux
it's incredibly
graphiques
challenging.
tirés de la
So here we
littérature
have two
pour vous
graphs
montrer
that have come
que
from the
même si les
literature which
professionnels de
show
santé ne
you
font pas
that
tout à
even
l'état de
if
santé de la
the
population, ils font
healthcare
quand même
professionals,
un
the
petit peu quelque
HCPs,
chose
are
et
working
de
hard, they don't
façon
actually
assez compliquée
they're
et
not
assez
actually able to
dépendante du
meet all
reste
of
du
the
système.
demands. So they are
Vous avez là
incredibly
deux
dependent on the rest of the
graphiques qui
system.
vous
So in these two
illustrent le
graphs,
lien
you can see the
entre la
fact that they
densité
are
de sages-femmes, le nombre de
illustrating
sages-femmes pour
the
10 000 habitants,
relationship between the
et deux paramètres,
density of
l'état de santé, la
midwives
mortalité maternelle
and
d'une part et le taux de naissance
maternal
par césarienne d'autre part.
maternal
Sur votre
mortality and
diagramme de
the
gauche, vous voyez sur les
rate
petits
of
points dorés
cesarean
que dans les
births
pays à
So in lower middle income countries, everything depends on the density of midwives. The lack of midwives leads to a higher level of mortality in maternity wards. So on the left-hand side, you can see the blue spots is actually in the area of the graph, which is actually quite low. And it's not necessarily due to the density of midwives, which is going to lead to maternal mortality. So on the right-hand side, you can see the rate of cesarean births. The recommendation of the WHS is also the WHO is that it's roughly about 15% of the total number of births around. So those are cesareans essentially. And you can see that the more midwives we have, we're going to be upping the number of cesarean birth rates because they're able to intervene when the birth is going to be riskier. So if we up the number of midwives, then actually the recommendations are that we're going to be lowering the number of cesarean births because they will be able to step in without having to resort to a cesarean. So I hope that's clear. So to reason, how many midwives do we need and how much is that going to affect the population? It's very difficult to come up with some very specific and accurate data, as I'm sure you can appreciate. The second example is to do with the relationship between the number of HCPs and the population. So first of all, if we looked at resuscitation units, the ratio of patients to nurses has an impact on specific criteria such as mortality and readmittance within 60 days. So these kind of arguments do exist with regard to, for example, falls for geriatric patients, nosocomial infections. So there are regulations to do with the ratios. So now we understand that that actually will be completely relevant to plan out the number of healthcare professionals that we will need in the future. Then we need to understand how many we will need in 10 years, how many there are at the moment, how many so we need to understand how we can identify the output under the present conditions, how can we understand the input under the present conditions, and come up with the following formula. So I'm going to skip past this and you'll understand that it's actually very, very challenging. So how can we define how many we need in 10 years? And generally speaking, there are two methods to do so. First is the estimation based on current needs. So the current needs of the population. So if we're talking about the current system, then we would say, okay, what is the quantity of consumption of healthcare given specific age groups and demographic projection, and then we'll understand roughly how things will be in 10 years. If we looked at a satisfactory situation, then we would talk about the ratios put forward by the WHO, etc. And these models are very advantageous because we can actually put other criteria into them, such as epidemiological changes, and the change in healthcare professionals' competencies, potential crises, technological advances which might affect stuff such as radiology, and healthcare professionals are very content with this potential approach. The issue is that why we only don't do things in such a way is that we have to take into consideration a whole other range of factors, such as the revenue of countries, and that, of course, will have an impact on the number of healthcare professionals which will be trained. In countries which have lower levels of income, then it's not just about the money required to train these professionals, but also to pay them. We need to look at what employers are doing, how many are they going to be needing, and how many are they planning on training. This is not going to guarantee that we can respond to the needs of the population, but I think that will give us at least a little bit of a clearer piece of information about how things will be. So globally speaking, this is how we do things in France. For example, when we spread out the number of interns and take into consideration things such as epidemiological factors, that's roughly how we do things in this country. satisfactory. So as you can see, our x, which is a very important part of the equation, we have two different ways of determining it. First of all, how can we define both? And then when we think about the effect that this will have on the population, we need to add into hypotheses, such as the current state of health of the general population. Let's look at why. This should be easier. So how can we count the number of HCPs which are available? But the thing is, a lot of the time, this data isn't actually very accurate. In some countries, there's no data whatsoever. So if we look at France, we do have a good number of, so we've got a good idea of how many doctors there are, but not so much for nurses. So how many are we going to be needing? How many are going to retire? How many are going to change jobs or leave the profession for other reasons? How many are going to be coming in? How many students will there be? How many arrivals? How many exits from the area? So how can we calculate all of that accurately? And next up, we're going to see that there are several different issues. So I'm going to be speaking about the ONDPS, and they have been very brave to publish this graph. And you can see the dotted lines, which are the projections which were made in 2005 about the number of dentists. So you can see the dotted green and blue lines are, or purple if you like it, are going down. And what's actually the situation at the moment were the red and blue lines, the solid lines. So they weren't actually that accurate, their forecasts, I mean. So you can see that actually there has been a huge amount of dentists coming in from overseas. So we're talking about dentists who have been trained overseas. They've come into the country and they've not been taken into account in the census, if you like. So we can imagine that countries that have large flows of immigration into the country, really, all of this is really going to affect the forecasts which were made in the past. Let's look at our planning. How can we define these several different methods which will help us reduce the difference, so x minus y, so those coming in and those coming out? You can see that actually the results are fairly blurred. There are different ways of doing so. The first is to look at X and say, okay, X isn't very accurate. How can we understand what the current health status of the population is? And I'm not going to go into too much in detail. I can say that we do have very powerful mechanisms which will help us. And then just after this, we have two different levers: increasing the number of HCPs which are coming into the field. This is going to take some time, or reduce the dropout by trying to make sure that HCPs stay loyal to their trade. Let's look at the ways that we can increase the number of HCPs. And I'm going to add in another element, which is how we can try and convince them to go and work in areas where they are most needed, such as for vulnerable and poor areas and poor populations. So, for example, how can we convince them through extrinsic motivation? So things such as financial incentives, stability, all that kind of thing, staff assignment, regulations. And I'm going to focus on what I know the most, because that'll be easier for me, which is all about intrinsic motivation. How can we make sure that HCPs are going to want to go and work in the poorer areas of Marseille, for example, or in the poorer areas of other cities? So we have two very important documents, recommendations from the WHO and another one from another organization. So we have other ideas, and I wanted to show you this slide here. This is what happened in American universities for medical schools, whereby they are positively discriminating students coming into medical studies. So as you can see, there's been an affirmative action to ban the enrollment of students from underrepresented racial and ethnic groups in US medical schools. I'm not going to talk about the current American government, but as you can see, the square dots represent the students coming in, which are from racial and ethnic groups that are underrepresented. And there was previously a positive policy to do with discriminating these students. So you can see that actually the this positive discrimination approach has not been working. So the round dots are actually going down, whereas the square dots are remaining relatively stable. There are other arguments in the literature which states that actually the needs are not being met. Let's have a look at the second type of strategy, which has an impact on the content or the place where medical studies are happening. So there's been a relatively recent meta-analysis which shows us, even if it's very difficult for us to get accurate data, they do still need more strategies, such as, for example, positive discrimination for students coming in and for different courses, different curricula. And how can we really get an accurate overview of the situation? We can see that generally things are working, but it's not easy. So I'm going to try and be optimistic now, but at the same time, there is some bad news. We don't know what X is. We know that data about Y is incomplete. It's really very difficult to predict who is going to be leaving the field. Increasing the IN is very slow and expensive. And when you don't have HCP, they don't always work where you most need them. So I think this is the kind of thing which we are going to be speaking about a lot this morning. And so it's very difficult to increase the accuracy of data for Y, but we need to be doing that. I'm not going to speak too much about all of this, but we do need to make sure that things improve, otherwise we'll be in trouble. So getting students into medical studies is absolutely pivotal. The same goes for doctors and for nurses. So we also need to be interested in the qualitative part of medical studies, because they're going to have an impact on the place that the healthcare professional is going to end up working.